Hi, this is Brian Kim. I'm going to share with you this case of a patient with a traumatic cataract that was referred to me. There's also anterior capsule fibrosis, and I also get an anterior capsule tear, and that is because the area of capsule fibrosis leads to and causes this area of anterior capsule tear. And you're going to see how and what I should have done differently to minimize the risk for the anterior capsule tear, but also how to disassemble the lens very carefully and atraumatically without propagating the anterior capsule tear posteriorly by doing double chop and cross chop and mechanical fracturing techniques. So this is the cataract. You can see that area of whitening in the area that's closer to me. I use a corneal marker which will help me to center and size my rhexis. You can see how there's a clear delineation of the lens in that traumatic cataract there. That is probably the endonucleus that's clearly delineated. I'm making my paracentesis incisions first on the right side and then the left side, making sure I'm parallel to the iris plane to allow me to achieve a self-sealing incision. This is intracameral lidocaine and then intracameral epinephrine, and this is some air. And this is some trypan blue. I'm going to paint the anterior capsule surface with it as well. In these cases, when there's a higher risk for anterior capsule tear, it's a good idea to put trypan blue in the eye. This is some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, use a cannula to turn the eye towards me, and then I enter. And this is the cystotome. I'm going to use the cystotome to start the capsulotomy. I did not have the sharp tip Haldane-Percars developed at this time. You can see that I made the tear and it's getting close to that area of fibrosis. I'm starting to pull. And it seems like I got all the way around the tear, which was good. And it seems like I got around the area of fibrosis pretty easily there. So I'm going around circumferentially, and that's the end of the rhexis. So you might think, okay, that's no big deal, looks pretty good here. So this is the capsular fornix hydrodissection technique. I place the cannula out under the rhexis edge contra-incisionally, get a nice wave, decompress on the left side, turn the tip to the right, and I begin to spin the lens. And as I do this, look what happens. There is a radial tear right there. And so how did that happen? I thought I had a continuous curvilinear rhexis, but now you're going to see here, first of all, you can see a jagged aspect of the tear there. Even though it was continuous, if you look more closely, there looks like a V-shaped jagged edge to the rhexis just underneath that area of the fibrosis. And so as I try to turn the lens by putting the cannula on the right side, as you can see there, it must have hit the capsule right there, stretched it, and then it radialized. So while I was trying to rotate the lens after my hydrodissection, the cannula, as I pulled the lens down towards me, I must have encountered the capsulotomy, stretched it, and then it tore. So I put some more viscoelastic in to flatten the anterior capsule, and then I'm going to try to salvage and try to get that radial tear to turn by performing the little maneuver. But all it does is just stretches it. And so it's already gone all the way out. And try to use a cystotome to see if I can create some kind of a can opener areas to help release the tension. That didn't work. So now I'm going to use micro scissors to go in, and I'm cutting contra-incisional to me, and I'm also trying to cut on the sides to me. And the purpose of this is to diffuse the weak forces on the capsule. By diffusing the weak forces on the capsule, and it's not just a singular point, it should in theory help reduce the risk of a posterior extension and run out. So I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. I'm going to place the chopper underneath the rexus edge, contra-incisionally. You can see, again, where the endonucleus is. So I can go right there. I turn the phaco tip vertically subincisionally, fracturing the lens completely in half. That is the double chop. You can see it's a nice chop there. Place the chopper around the right heminucleus, pulling it centrally toward the phaco tip. When it encounters the phaco tip, it just fractures the lens in half. You can see that the lens is pretty loose here, so I start to use ultrasonic energy and high vacuum to start to remove the first and second quadrant there. And so the lens just wants to come up, so that turns out not too bad there. I begin to fracture the lens by sandwiching the lens between the instruments once again. And then begin using mechanical fracturing principles to crush the lens into smaller and smaller pieces and then emulsifying the lens piece. But that first maneuver, doing the double chop, that was the key. I didn't have to sculpt. By sculpting in this situation, that'd be very dangerous. It could increase the risk of propagation of that tear, but I didn't have that happen. I have a little stubborn piece of lens underneath me, so I come out with a chopper and I'm using a cannula to tease that piece back up so I can access it with the phaco tip easier. And then I'm able to use some vacuum to grab it and then emulsify the piece. And I use a chopper to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out and go in with the ironing handpiece. Going to try to start to peel the anterior capsule from anterior to posterior. You can see the radial tears there, especially the one contra-incisionally. Similar to the subincisional anterior capsule tear, it's pretty wide tear, but this would be analogous to me when you get like an Argentinian flag. Again, in most of those cases, the tear force is anterior and it doesn't propagate posteriorly unless you cause it to. If you create some type of force to want it to propagate, then it may happen. But in these cases, usually you'll have an anterior capsule tear and it won't propagate unless you do something wrong. All the cortex came out quite easily here. I want to be mindful as I'm polishing that I don't cause any traction on the anterior capsule because it is discontinuous and you don't want to exert any forces on the anterior capsule, which can cause that capsular tear to wrap around posteriorly. So I decided to go directly with the cohesive viscoelastic to fill the capsular bag. And you want to do this very slowly and you don't want to overinflate because there is a discontinuous anterior capsulotomy. So this is single piece acrylic lens. It's going to go into the capsular bag. I really like the single piece acrylic lens in this situation because it opens up very slowly and you can position the haptics perpendicular to the tear as you see I'm doing here. And these gummy haptics are very, very tacky and the lens won't spin and cause a dislocation down the road. I have a lot of confidence that this is going to be a very stable and secure situation. So I go in with irrigation off, activate irrigation. Make sure there's no viscoelastic underneath the lens because, of course, as you're trying to remove the viscoelastic, as the viscoelastic comes out from underneath the lens, it can cause the haptics to rotate into the area of the tear, and you don't want that. You want to make sure there's a very solid positioning of the haptics away from the tears. Removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So you can see at the end of this case, there's excellent overlap of the optic, with the exception of the area of the tears. It's a good size rexus. You can see the haptics are completely away from the areas of the tear. And this patient, although there was anterior capsule tear, was able to disassemble the lens quite easily, performing double chop, cross chop mechanical fracturing principles, using forces towards the center away from the zonules in the capsule. By doing it this way, it reduces the risk of tension on the capsule, which reduces the risk for a posterior extension and a runout. You saw that you never want to try to create a capsulotomy in the area of fibrosis. So that's the lesson learned in this case. With the idea and desire to get a well-centered and sized rhexis, I was trying to force the issue by making the capsulotomy smaller. And by doing it this way, I made my rhexis right over the area of the fibrosis. Unfortunately, the area of fibrosis will then not really quite be continuous. I think it's more like a stamp. There's some jagged edges to it. So even though I pulled it and I looked like I got a continuous rhexis, in that particular area, it must have been more jagged because you did see that little step off, almost like a sharp V shape aspect to that capsulotomy right underneath the area of the fibrosis. And of course, as I did the hydrodissection and then I was mobilizing the lens, when I pulled down on that area, it just split open. Normally, if I did create any tension on the anterior capsule opening with the cannula, it shouldn't extend that way. But of course it did. And so what do I have to do? I don't want to continue to go with the case and worry that it might cause an extension. So I created another cut separately on the other side to help diffuse some of those forces, so it's not just located over that one weak spot. By doing it this way, the goal is to help reduce the risk for a posterior extension. Thankfully, everything went well. The haptics were positioned perpendicular to the anterior capsule tear, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.